The next presentation will be by Naomi Rabinovich, and the discussion is going to be, is prophylactic central neck dissection necessary when there are lateral neck metastases? Thank you.
Good morning, everyone. So I'm Naomi Rabinowitz. Like Dr. Alon, I'll be speaking instead of Dr. Bacha, which unfortunately could not attend today due to the security situation in Israel. So I'll be discussing the necessity of prophylactic central neck dissection when there are lateral neck nodal metastases. And how do I move this forward? Back. Okay. Okay, and just to kind of get the feel of this dilemma, let's say this patient presents to you with lateral nodal metastases. I imagine most of you would offer her total thyroidectomy, lateral neck dissection, and maybe central neck dissection also. But what if this patient had already undergone total thyroidectomy in the past and during follow-up presented to you with lateral metastases? Do you perform prophylactic neck dissection other than the lateral neck dissection? Of course, bearing in mind the potential complications of reoperation in this area. So the problems we're facing are that central lymph node metastases cannot be reliably diagnosed pre-op, as was also mentioned by the previous talkers. We're not sure about the significance of the central lymph node metastases in the dissection on the patient's outcome. And the third problem is that the management as a whole of central lymph nodes in papillary thyroid carcinoma is still controversial. We have a lack of large prospective and randomized controlled trials, mainly due to the indolent course of this disease. And going back to basics, we know that metastases to original lymph nodes are common. They occur in approximately 30 to 80% of papillary carcinoma patients. The most common metastatic sites are first the central neck, followed by the lateral cervical, and then the mediastinum. The lymphatic metastases of papillary thyroid carcinoma tend to occur in the ipsilateral central compartment in about 70%. It next spreads either to the ipsilateral lateral compartment or the contralateral central compartment in about 10 to 20% of the cases. Metastases in the lateral neck may be derived directly from the thyroid, or they can be sequential from the central neck. And looking at the incidence of central lymph node metastases, Sadowski in 2009 looked at 180 patients out of 300 who underwent central neck dissection for papillary carcinoma. He found that bilateral central neck yielded an average of 11 lymph nodes, while unilateral yielded only 5. The central nodes were positive in almost half of his patients, and a quarter of them with bilateral central neck dissections had positive contralateral nodes. 5% of these patients had positive contralateral nodes, even without any evidence of metastatic spread to the ipsilateral nodes. So we should maybe keep this in mind. Moving on to this interesting concept of skip lateral metastases, we define that as lateral compartment disease without involvement of the central neck. Drale wrote a lot about this. In his study, he found up to 38% of the papillary carcinoma patients having skip metastases. And he also found that unattended positive central neck nodes exposed the patients to tracheoesophageal invasion. That's another study, 2010. Park et al. Found 22% of skip metastases in papillary carcinoma patients. He found that it occurred commonly with tumors of the upper pole measuring less than 1 centimeter. He found it was less common in multifocal disease, and that patients with these metastases had fewer metastatic lateral nodes, and they were more frequently found at a single level, mainly the third level and then the second. So we're basically trying to balance between the risk of recurrence to our patients versus the morbidity of performing central neck dissection in a reoperation setting. So this meta-analysis published in 2010 looked at 5 studies. They were retrospective, accounting for over 1,200 patients, and they found a trend toward lower overall recurrence in the group who underwent either uni or bilateral central neck prophylactically when they compared it to those who had only total thyroidectomy. They concluded that there might be a potential benefit of lower recurrence in those patients who underwent prophylactic central neck dissection. So what about the complications of doing a revision surgery? We know that the revision surgery was associated with higher rate of impairment to the recurrent laryngeal nerve. That was published one of the many articles in 2010. In 2007, Erbil found that repeat surgery had a 3-fold increase risk of post-op hypoparathyroidism. And looking at the morbidity of the prophylactic central neck dissection, this systematic review comprised 5 retrospective studies. They found only 1 extra case of transient hypocalcemia for every 8 central dissections performed, but there were no increased risk of permanent hypocalcemia and any kind of injury to the recurrent laryngeal nerve, transient or permanent. And to date, there are no studies that have shown an increased risk of permanent hypoparathyroidism or recurrent laryngeal nerve injury. And looking at the NCCN guidelines, I'll get to the ATA too in a minute. They state that if the neck nodes are negative, we should consider prophylactic central neck dissection, level 6. And again, looking at the ATA guidelines, recommendation number 26 states that comprehensive central neck dissection may improve the survival and reduce the risk of nodal recurrence. They said that selective unilateral paratracheal central compartment dissection increases the proportion of patients who appear disease-free with unmeasurable thyroglobulin about 6 months post-op. And this recommendation was already mentioned, but again, they say that we should perform prophylactic central compartment dissections, especially for patients who have advanced tumors of the thyroid, such as T3 or T4. And if I'd like to summarize, we know that subclinical central lymph node metastases are common. They lead to high recurrence and poor survival. Prophylactic central neck dissection may reduce the recurrence and lower post-op thyroglobulin levels. Pre-op evaluations of the central compartment are not reliable. Performing prophylactic central neck dissection may improve the tumor staging. It reduces the need for reoperation in the central neck in case of recurrence, which is, as was mentioned before, is associated with greater morbidity. And prophylactic central neck dissection may be safely performed in comparable morbidity to thyroidectomy alone. And again, this in the hands of experienced surgeons. So going back to our patient, well, we believe that prophylactic central neck dissection should be considered rather just to wait for the recurrence to emerge. Again, we're balancing the patient's moderate risk of local recurrence against the risk of surgical morbidity, and at least unilateral prophylactic central neck dissection rather than a bilateral one should be considered, as it provides a balance between achieving all these surgical goals and avoiding the significant surgical morbidity that may be associated with that. So I'd like to thank you, and if you're not mistaken, it's not New York, it's actually Tel Aviv, and thank you.